So for those of you who don't know me, I'm one of the peds pulmonologists at University of Maryland. It's the two of us, and then we have a nurse practitioner as well. So feel free to reach out to us if you have questions afterwards. So we'll try to make it like a very interactive session. I'll try to keep it short, and then we can go into questions, because I know there's a lot of practical application. So my talk today is going to be about smart therapy, but also very basics of it. What is it? Why are we going to do it, or why is it recommended, and how do you actually make it happen in the outpatient world? I will be discussing off-label use of medications, but I have no financial disclosures. So we're going to discuss three major objectives. The first is going to be to discuss the highlights of SMART for asthma management. We're going to review evidence supporting SMART in the pediatric age group. And also discuss practical implementation of smart therapy. So, before I go into smart therapy, I wanted to talk about the two major guidelines that we have for asthma. And you all may already be familiar with this, but just to put it out there, these are the two main ones. So if you ever need to refer to anything for step therapy, these are the two you should look at. The first one is the GINA guidelines, or Global Initiative for Asthma. And this was established in 1993 in collaboration with WHO and NHLBI. They put out guidelines every year, so it's extremely updated, and they review literature twice a year. And it's a worldwide effort. So in this case, it's important to note it's not really funded by a country. It's self-funded, and so it's important that what they put out is very much evidence-based and not supported by one view or the other. The other set of guidelines are our own U.S. NAEPP guidelines, which are National Asthma Education and Prevention Program. So they put out guidelines every 5 to 10 years, and the last one that came out was 2007 and was updated in 2020. So you can see there was a 13-year gap. But they updated 5 major portions in the actual guideline. One of them was smart therapy. So 2-3 years ago, I think I did a grand rounds on just updates in 2020. And today, one of the updates is smart therapy, so we're just going to talk about that. Okay. I just wanted you to know that there's a lot of things that the guidelines agree upon, which is actually smart therapy and how we treat patients who are moderate to severe asthmatics. But then there are things that they don't agree upon, which is the mild asthma. How do you treat mild asthma? So I'll go over that too and show you the discordant thoughts in those two things. So there is a big change now in how we think about asthma and asthma treatment, and it's just a huge paradigm shift. And it all stems from the fact that there's lots of research showing that SABA alone is not always as effective as we think it should be. There have been studies that have shown that even 1 to 2 weeks of continuous SABA use only for asthmatics has led to increase in airway hyperreactivity just by itself, beta receptor downregulation, sometimes even increased airway inflammation and increased eosinophils for the period when you use just a SABA in an asthmatic. And the whole problem becomes when you think that a SABA is your treatment for asthma. Because when you see patients in the clinic and they'll be like, yeah, this is my inhaler. And they'll show you the albuterol inhaler. Like, no, what about the everyday inhaler? And so that's always something that we struggle with. And then patients tend to regard this as their primary asthma treatment. And so adherence to daily inhaled corticosteroid becomes very hard. And so what these guidelines are showing is, you don't need to always use just a SABA as your reliever. And you don't really need to use a daily ICS every single day if you don't have symptoms every single day, which is kind of like a little medium in there. And that's, so I do want to point out that what we're doing right now is not wrong. What we are used to right now is the SABA for mild asthma, then you add the inhaled corticosteroid for moderate asthma, and then you add the LABA for the severe asthma. That's still, if it works, it's fine to use for patients. But we just have more literature out there for moderate and severe that we'll discuss today. I want to go back into terminology before I go into SMART per se. So these guidelines actually mention, yes, we are going to talk about SMART, but then there's also something called anti-inflammatory reliever therapy. So because SABA alone are not the best thing, they are now recommending that anti-inflammatory reliever therapy is what we should use. So what they're recommending here is for mild asthma, which is step 1 and 2, AIR actually means that for under 12-year-olds, you can do a low-dose inhaled corticosteroid whenever you're doing the SABA. So you don't always need to use a daily inhaled corticosteroid for the mild patients. They're also saying for the older than 12 years old, you can use ICS formoterol or Symbicort for as needed symptom relief only. It's for mild asthma, this AIR therapy, and I'll talk more about this in detail. Smart therapy, on the other hand, means that there is a daily Symbicort on board, but there's also rescue Symbicort on board, right? That's the difference. It's only for moderate to severe asthma, so step 3 and 5, and it's only for patients older than 5 years old. It's not for under 5, so we'll talk. So single maintenance and reliever therapy is the new approach we're talking about. There's 2 medicines in 1 inhaler, typically only formoterol with the ICS. It's effective because it's only 1 inhaler, so if they want to carry 1 inhaler, that can be their inhaler. And it has anti-inflammatory and long-acting bronchodilator capacity. So we're going to talk about asthma guidelines by age, because that's just how we see it in the hospital. I'm going to start with the easiest age group, which is the adults and the adolescents, because that's what's out there the most. So what they recommend here is patients with mild persistent asthma, we can do PRN Symbicort instead of PRN albuterol. So we do PRN Symbicort, and that's going to be our mild asthma recommendation. And this is something that GINA guidelines put it as this. So I'm going to break it up a little in this. So if you see, this is familiar step pattern that you already know for asthma. And here what they are saying is they are dividing it into track 1 and track 2. Track 2 is something that we're all familiar with. You start with the low-dose ICS, then you increase to a maintenance LABA, then you make it medium or high-dose ICS, and then you add on a LAMA if you need to. That's just something that we know already. The track 1 that they're actually referring now as a preferred track is that we use for step 1 and 2 a low-dose as-needed Symbicort. And a reliever should also be a low-dose as-needed Symbicort. So if you see, the major difference is that in track 1, your reliever becomes a Symbicort reliever, whereas your track 2, your reliever is the same, your SABA. We'll talk about who needs which track, okay? So that's what we're referring to now. I'm talking about just this. We talked about how the guidelines are different, and that can be sometimes confusing. So NAEPP guidelines still recommend for step 1 a PRN SABA. So what we're doing is not wrong. It can still, so it's just that there's a lot of evolving literature out there. And these came out in 2020. The GINA guidelines came out in 2021. So we have that kind of dichotomy in step 1. But going forward, they do recommend, yeah, sure, for step 2, use low-dose daily inhaled corticosteroid and a PRN SABA, or use a PRN ICS and a SABA. Does that make sense? Let's talk about moderate to severe asthma. So this is the kind that is a little bit less controlled with, not really controlled with a low-dose inhaled corticosteroid in your clinic. In these patients, you use ICS formoterol or Symbicort as your daily and your quick reliever therapy, as opposed to a high-dose ICS. For example, instead of using a Flovent 220, you're going to instead use Symbicort 80. So you're limiting the amount of ICS, but then you're giving that formoterol additionally. They also recommend to add a LAMA, which is a long-acting muscarinic agonist, which is ipratropium in these cases, later in the step therapy, not initially. So it's like towards the end, once you are not controlled. And at that point, you're referring to a specialist. So this is the step that we're talking about, step 3 and 4, where we're doing low-dose maintenance ICS formoterol or a medium dose. And your reliever is as needed Symbicort as well, the same inhaler. Which patients need track 2? These are the patients where insurance for some reason doesn't cover an ICS formoterol. And these are also the patients who are actually well controlled in your clinic. You don't need to switch them. You don't need to make the whole process difficult for them if they're doing well and have had no exacerbations in 1 year. because it does need a lot of teaching, and I'll come to that. What is the evidence behind? So this we're coming to why of SMART now, and the evidence behind it is that there was this huge study, clinical trial done over 2 years, two-part clinical trial. The first part compared Symbicort to as-needed SABA for mild asthma. And they saw in that graphic, you can see that if you used as-needed Symbicort instead of as-needed terbutaline, your risk of exacerbations decreased by 60 to 64%. That's actually more than even what a biologic does. It kind of decreases by 40%, but this one's like much more. They then did a second trial as a part of that, where they tried to compare, is Symbicort better than low-dose maintenance Flovent? And they actually found that it's actually not inferior. It's not better, but it's also not inferior to it. So it was a non-inferiority study where they showed that it was actually able to control the rate of severe asthma exacerbations. However, the daily symptom control was not as great. But again, if we're looking at trials, we're also thinking these patients know they're in a trial, so they're going to take their Flovent every single day, whereas in real life, it doesn't really happen. So that's something to consider as well. Why formoterol? Why are we all kind of just saying formoterol? If you look at, this is what explains it really well, and I think if you look at the 30-minute mark, the blue line indicates formoterol, and the red indicates our beloved albuterol. And so if you look at this one, at 30 minutes, the change in FEV1 is the same for both. The onset of action is pretty quick as well, and this was based on a pretty extensive randomized trial that they did on patients who received different inhalers. And so they found that formoterol does a very good job at that quick relief, but also stays in your body for a long time. The rate of, this was a systematic review and meta-analysis. So now we're talking about data in 12 years and older in adult population for SMART therapy. And this was a systematic analysis and meta-analysis that was done of 16 studies that were all using SMART as opposed to conventional, and all were randomized control trials. And they found that all of these showed that SMART therapy was much better in reducing risk of severe exacerbations as compared to same dose ICS-LABA therapy and a SABA as a controller, as a reliever, sorry. They also compared it to a higher dose ICS-LABA, and they found that it was still better than a higher dose ICS-LABA, which was interesting. Let's talk about time to first severe exacerbation. So this was a 12-month double-blind parallel group study that was done in patients who are older than 12, close to 3,000 patients. They were randomized, so they were all on a Symbicort inhaler for two weeks. And then they were randomized into 3 different reliever medications, The first one was as-needed terbutaline. The second group got as-needed formoterol as reliever. And the third group got as-needed Symbicort as inhaler, as reliever. And they found that the ones who got as-needed Symbicort as reliever actually had the longest time to first severe exacerbation. So what they're trying to say is if you try to give a small dose of inhaled corticosteroid like Symbicort, even during a flare-up, it's going to reduce your chances of having a severe flare-up. Let's talk about under 6-year-olds. Always tricky. So in this case, we don't have as much literature. That's the problem. And hence, we don't recommend for step 1 and 2 the Symbicort. Okay? For these patients, we recommend just the inhaled corticosteroid, the Flovent that you're using, but a low-dose Flovent. And you can use it daily, twice a day. But when you are to a point where you get to the moderate and the severe, your SMART therapy data is there. So we'll talk about that. But here, this is one thing I want to point out is step 1, they do recommend to take a low-dose inhaled corticosteroid whenever a SABA is taken. This is new recommendation. So what they're saying now is that for patients who are extremely mild asthmatics, they have symptoms maybe twice a year, and they come to you and they're under 12 years of age, you can tell them to take your Flovent for a week while you get sick, while you take your albuterol 4 times a day. or 6 times a day that week. So we're just saying that use this flow vent when you're sick and then stop it when you're not. When you reach to a point where you're not controlled on that, you're still having multiple flare-ups and oral steroids, you then do the low-dose daily flow vent. This study is the only study which is double-blind, randomized control in pediatric age group in mild asthma, which talks about use of inhaled corticosteroid as needed with the SABA, only when required. And this study was done in 2013, was way ahead of its time, I think, and it was a really good study. Came out of Arizona. There were patients that were, I think it was like 250 patients between 5 to 18-year-olds. The primary outcome was what's the time to first exacerbation if these patients are getting rescue therapy versus combined everything. So just to make it a little easier, the blue lines indicate that your inhaled steroid, the solid blue line indicates that your inhaled steroid is only taken as a rescue. Okay? The dotted blue line is a placebo. Nothing is given. The red lines indicate you're giving everyday, daily inhaled corticosteroid. So that's what we're showing. And they wanted to show 2 main things. What is the time to first severe exacerbation, which was actually less in these 3 groups as compared to the placebo. So if you're giving rescue inhaled corticosteroid, it's still comparable to daily inhaled corticosteroid. The second thing they looked at was secondary outcome of linear growth. And let's take a look at that, which we're all concerned about in pediatrics, right? So if you look at the red lines, these are the 2 that got daily inhaled corticosteroid in some form or the other. The blue lines are the one that the solid blue is rescue ICS only. And if you see, it's the growth change is comparable to placebo. So there was a 1 centimeter difference in these 2 groups at the end of the 44-week trial, which at the end of 1 year, you're growing 1 centimeter more. I would take that. So they recommend from this study is that if you have a controlled asthmatic, you can step down to as needed flow vent. You don't step down to just as needed SABA. Say you don't need anything every day, you can take it as needed, but take both inhalers at the same time.
And twice a day.
Right, flow vent twice a day, yeah. NAEPP is still recommending for the intermittent asthmatics for this age group, PR and SABA. So just wanted to point it out because you will see this when you look at it. And I think it all ends, in the end, it's all about individualizing to the patient. Many a times, some families you'll see will not understand the use of these 2, and they'll end up using one or the other too much. So we can always tweak it to the family. Smart therapy in under 12 years old. There's good data, and this is what I wanted to show you. This one study, there's only one study, but it's a good one. And it basically shows that there was a 12-month double-blind randomized study in 350 children between 4 to 11-year-olds. And these all had uncontrolled asthma on a daily ICS. They divided these patients into 3 groups, one who received smart therapy, one who received Symbicort for maintenance, but not for relief, right? And then the third one who received only budesonide and a SABA for rescue. And this is what they found. So if you look at this graph here, you'll see that the solid black line is smart therapy. And it shows the time to first exacerbation was much more prolonged in smart therapy as compared to the other 2 groups. And it was significant, the difference. And they also found that if you look at the rates of severe exacerbations that require medical intervention or oral corticosteroids, smart therapy reduced it by 70 to 80% in 5 to 11-year-olds. And mild exacerbation days and awakenings were also significantly lower with smart therapy. What's better, they also looked at growth. And they looked at how this is affecting growth, and they found that at the end of 1 year, this is the second study showing that the growth was 1 centimeter more in the smart patients as compared to the conventional patients. So for severe therapy, they're saying that this is helping a lot. Asthma in under 5-year-olds. Very controversial all the time. Do we call it asthma? How do we treat it? And we'll talk about that a little. So in patients who are 5 and younger, we're recommending to use the same step therapy that you had before. So there is no smart therapy for under 5. There's no research, so not recommended. I have a few patients that I'm just waiting that they can just turn 5 years old or 6 years old, because they can then be take biologics or get smart therapy. There are kids who are really, really severe in Baltimore. But I think we have a lot of patients who are mild, and there is some recommendations that are different, and we'll talk about that. Viral-induced wheezing. So NAPP has actually recognized that there is something called viral-induced wheezing and reactive airway disease, where children who are 0 to 4 years of age with recurrent wheezing just with illnesses can get a short 7 to 10 day course of ICS as needed with ASABA for quick relief. So the same recommendation that we just talked about for mild asthmatics between 5 to 11 can be given for under 4, even if they are not diagnosed with asthma. And so here, this is what they're recommending. They're saying, let's do a PRN SABA at the start of an illness, but then at the same time, let's do a short course of daily ICS. And I usually tell parents, I'll write it in their plan, say when you get sick, you use both your inhalers, both for 7 to 10 days, but one is twice a day, and the other one is every 4 hours. Step 2 remains the same. You use daily low-dose ICS and a PRN SABA. And then step 3, 4, 5, it's the same. You do medium dose ICS, you go up to high dose ICS, and then you add a LABA and oral corticosteroids. Actually, LABA is not approved for under 6 years old also. There's no LABA out there that's approved for under 6. We do sometimes off-label use of LABA if we don't want to do oral corticosteroids in these patients a lot, if they're coming to the hospital. But I have maybe patients that I can count on my fingers, maybe 2 that are on a LABA that are under 6 years old. It's not that we cannot diagnose asthma under 5, and I do diagnose kids if they have these symptoms. Cough. So I'm going to talk a little about this. So recurrent or persistent non-productive cough that's worse at night is a big symptom of asthma. It's a more common symptom of asthma than even wheezing. So if someone says, my child is coughing every night or 3 nights in a week, even without an illness, that's a sign of asthma. Cough with exercise, laughing, crying, or exposure to smoke, like any sort of trigger, is a sign of asthma. Wheezing, recurrent wheezing between URIs, not just with URIs. So if it's between URIs with exercise or laughing or crying or anything like that, or perfume exposure, things like that, at that point I'll say, okay, this does go towards diagnosis of asthma. Heavy breathing, shortness of breath with triggers. So if child is running and parent has to stop them, that's a sign of asthma. Associated features like allergic disorders or food allergy, these are big. Like if parents have allergic disorders or patient themselves have eczema, food allergy, we're already thinking atopy, and you're diagnosing with asthma at that point. Therapeutic trial. So in these patients, or in any other patient that I'm kind of on the fence as to whether this is or not, I'll give a 3-month trial of inhaled corticosteroid, and I'll stop it. And if the symptoms come back, they prove that they have asthma. So that's the other way. And I tell the parents this from before. I'm going to give you a trial. We'll see how it goes, and we'll stop it. So how are we going to apply it in our clinical practice every day, right? Okay, so previously we were doing Flovent 44 mcg, 2 puffs twice a day. And if it's uncontrolled, this is just an example, we would increase to 110 mcg, 2 puffs twice a day, right? Now, and that can be still a possibility if there is no insurance coverage of Symbicort and all that. But now what we recommend for under 12-year-olds is if you have uncontrolled asthma, you can switch to Symbicort 80 instead of the Flovent 110. And you just do 1 puff once or twice a day. And that is going to help with PRN Symbicort is going to help control your asthma for step 3 or step 4 therapy. For patients who are greater than 12-year-olds, you can do Symbicort 1 to 2 puffs twice a day, depending upon whether they are moderate, step 3, or step 4. If they're step 3, you're doing 1 puff in the morning and 1 puff at night with as needed, right? If they are step 4, you're going to do 2 puffs in the morning and 2 puffs at night with as needed in between. But start with a 160 for over 12-year-olds and start with the 80 for the under 12-year-olds. This gives you everything in one spot. And so for 5 to 11-year-olds, for step 1 therapy, we're going to only use a PRN SABA. That's just the NHLBI recommendation. But you can, if you want, use a daily, and I recommend actually to use a as-needed Flovent in this group as well. The reliever is SABA in this group. They don't have a Symbicort reliever. Step 2 is when the ICS becomes a daily ICS. That's your Flovent 44, the low dose. Step 3 is when you add Symbicort 1 puff once daily. You can go up to 1 puff twice daily, or even 2 puffs twice daily, but the lower dose of Symbicort, which is 80. Okay. Dulera is the other option. No studies out there for Dulera. It just has mometasone formoterol, so it has the formoterol, which is the right medication. It's just that we don't have studies, because most of these studies were done outside in Europe or Australia, and so that's not one of the common inhalers used there. But it has formoterol, and so if there is a patient who cannot get Symbicort, you can try a low-dose Dulera. But it's only for Dulera 50 and 100, not for the 200. So I would stick to Symbicort. I'm sticking to Symbicort right now. So the big point here is that we cannot give more than 8 puffs of Symbicort in a patient who's under 12 years old. It's just because that's the amount of total dose of formoterol that has been studied in a day. So if these patients are getting Symbicort 1 in the morning, 1 at night, you can give 6 more throughout the day.
So potentially with the albuterol and we're just doing PRN SABA, we do every 4 hours.
Yes.
So with this, the Symbicort, what's the time frame? How often are you telling them if they needed it more?
That's a great question, yes. So with Symbicort, there's no minimum time frame that you have to wait. So you don't have to wait 4 hours. I tell them, take 1 puff, take another one after 5 to 10 minutes if you don't feel better. You can get up to a max of 4 puffs in a patient who's under 12 years old at a time. So if you're having a flare-up, like for example, I tell them if 8 a.m. you got 2 puffs of your daily Symbicort, and at 12 noon or 1 o'clock you feel like you're having a flare-up, you take 1 puff of Symbicort. You wait for 5 or 10 minutes, you feel still short of breath, take another one. Usually 2 are enough to help you, and usually 1 is enough as well. But beyond 2, you can take up to 4, but at that point, you're coming to the hospital. But there have been no patients so far that have needed 4 at a time. So they take 1, and then I say reassess your symptoms again 1 or 2 hours later. And they feel better usually, and they can usually go up to 2 or 3 hours, and then take another puff that time. So kind of able to go up to a max of 8 in a day. Then I tell them if it's like 10 p.m. and we've reached your max of 8 puffs a day, you can take albuterol after that every 4 hours.
So you do have albuterol in the home
Option.
with them also?
Yes.
Okay.
Right now I do. For the ones who are already on a 2 puffs twice a day therapy and they only have 4 more to go, I have the albuterol as a backup for them. But if I have someone on just a Symbicort 1 puff in the morning only as a maintenance, then I know they have enough puffs, like 7 puffs in a day to use, and they're not going to need extra albuterol. I'm trying to avoid SABA at home as much as possible, and I give them 2 inhalers of Symbicort. But I still give them SABA for school because insurance is hard, and then SABA extra for home, but I tell them that you'll reach this only as a backup, only if you're at that point where you've exhausted your 8 puffs in a day.
I think the hard thing, practically speaking, is the community, the grandmoms, the great-grandmoms, the cousins. Everyone knows albuterol. Everyone wants albuterol. And it's the confusion factor that is so challenging to deal with.
Absolutely. I think you're right, because like there is the shared responsibility of the kids, right? That's definitely there. And so at every time, every point that we see them, we talk about what are you using. I quiz them, and then they'll tell me this is what we're using. So I've had there've been admissions when we go and say they're on smart therapy, but then we go and talk to them. They're like, "We're using our albuterol as rescue," and that happens. Yeah, and that does happen. You're right. But there are certain families that have understood it as well, and then they'll just use their Symbicort.
But
So it's
the
getting
concern of how much albuterol on top of the Symbicort.
Yes.
Isn't there something where that's where some of the, there was concerns about not doing too much of that? And have you seen that bear out in terms of?
Mm-hmm. So far, for the ones who we have smart therapy and are using them, have not reached a 8 or 12 puff max for them. And then if they do, we ask them to do it like for 2 or 3 days at a time. So if you are using your Symbicort more than 8 puffs in a day, or total 8 puffs in a day, for 2 days in a row, we're asking them to call us and giving them oral steroids. So we're actually telling them, don't reach for your albuterol, call us in between, in the middle of the night, call us, so we can tell you what to do next, kind of thing. Yeah, but I think it is definitely a challenge, because you cannot give more than 8. You probably can, it's just not studied. So that's the problem.
And then just to clarify,
Yeah.
so are you writing for like 2 albuterol inhalers and then 2 Symbicort inhalers? Is insurance covering all of them?
So I'm ordering, yes. So I'm ordering 2, and I'll come to that, the prescriptions. But I'm ordering 2 Symbicort inhalers, and I'm writing in the note to pharmacy that this is 2 inhalers as a part of smart therapy. So many a times pharmacists will call us back. Initially, I was getting calls where, what is smart therapy? And now I get calls where we say this is smart therapy. Oh, God, we got it. And then it just goes through. So we've seen that with some insurance. Care First is actually covering 2 Symbicorts now. What else? The second, 2 albuterols. That one, I say 1 albuterol for school, for sure. And then many a times they have one from before. So then I'm like, stockpile them. Yes. So then, exactly. So then I'm like, keep those and we'll. So that's how we're working it out. Many a times, if they are only using 1 puff once a day of Symbicort, there is no need for 2 Symbicorts too. So if I have a trouble with insurance and they're like, no, we cannot give you 2 Symbicorts, but the kid is only getting 1 a day, 1 puff a day, that's technically going to last 2 months.
It's 60 puffs in.
Yeah, 60 puffs, yeah. So technically it'll last longer, so then I say, okay, wait. Or we'll challenge it or prior auth it one time, and you have 2 for the first month or 2 for the second month, and then we can go 1 a month after that, because you'll have enough. They are very understanding. Actually, I've had good response from patients. They are understanding of it. They want to try it. Because really the next option is biologic therapy, right? And it's like 30-35% chance of reduction in exacerbation, which we're seeing with SMART right now too. So this is what we have for 12 and older. The max is different, that's all. So you get 6 puffs on a single occasion, and you can get a max of 12 for 1 whole day. So very few are reaching that max, actually. They'll take 2 or 3, and they'll feel better, and then it's time to take the nighttime dose. So it helps. The long-acting action of the formoterol, I think, helps a lot, and that's something. So you see the difference here is only that you're using the reliever is only Symbicort, whereas here the reliever was Saba.
Do you see for those kids that are exercise-induced?
Yeah.
Sometimes we do like the pre.
Yes.
Out the
Yes.
Saba 30 minutes before.
Yeah.
What about if they're on something like this?
Yes. Also can use Symbicort pre-exercise. In fact, recommended to use pre-exercise Symbicort 1 puff because a quick duration of action. But I tell them to at least use 30 minutes before instead of 15 minutes before exercise. Just thinking that albuterol has a quicker action too, like 15 minutes. With that graph that I showed you, it does have a little bit, the change happens at 30 minutes, which is very equivocal. So 30 minutes before exercise using Symbicort is fine. In fact, I sometimes say, when is your practice? If the practice is in the evening, like 7-ish, just take your 2 nighttime doses at that time before exercise, and that takes care of the whole thing. So to avoid that. Emily, questions?
Sorry.
No, no, you're good. A good question, because I was going to come to that anyway. So Symbicort prescribing will look like this: 2 puffs twice a day with the spacer and the mask, 1 puff as needed for cough, wheezing, and shortness of breath. You can do 2 different prescriptions as well: 1 for daily use, 1 for as needed use, and and then it's actually easier to do 2 different prescriptions too, because if you know which one's not covered, then you can kind of fight on that and get. I use this a lot, and it has worked for me, the first one. The second one is for 1 for home and 1 for school, which is hard for a couple of reasons. I can give 2 for home, and parents understand that we can keep 1 as a backup. But if I try to do 3 inhalers, insurance is not going to agree. They have not agreed for 3 inhalers from any of the patients yet for me. Also, this max puff is a little challenging, because if you've received 4 at home and the school gives 2, how much communication are they having with school to know how much they've already received? And so I try to keep it simple for school and just do the albuterol right now, unless I have a better option. I've talked to colleagues elsewhere, and they're doing the same. So that's the only challenge that we have. Now, for the patients who are on 1 puff daily, you could technically use a Symbicort for school if you want to. It's an option, and I have seen these prescriptions being given at different places. So one of my colleagues at Kansas Mercy is using this second Symbicort prescription, where it has worked really well for them. So, outpatient exacerbation, what do you do then? So these patients need a lot of education. It's like we ask them to give us a call if they are having a flare-up, and just to go over the asthma action plan again. We tell them why not to just start a nebulized SABA, because many times they know their machine, they'll use their machine, and it's not ideal. Also, nebulizer versus inhalers. Inhalers are the more preferred modality. So we try to tell them why you should not just use your albuterol only if you have Symbicort. And for sick plan, I tell them you can use 1 to 2 puffs of Symbicort every 5 to 10 minutes as you go, but of course with the age-appropriate max in mind. If they're exceeding daily puff max even for 1 day, I'm asking them to give us a call. And we're not getting as many calls, though. I was expecting more, but I've really started doing a lot of smart therapy for the last 6 months. And my experience has been the insurance is now accepting more and more, and parents are more receptive to the idea also. And they call after 2 to 3 days of max daily puffs, they call, we give oral steroids. These are also the patients I'll give oral steroids on hand, and I'll say, call us if you are using them. Alternate formulations, can they be used? Let me just tell you, all the studies are only done on budesonide formoterol combination. Only 1 study is on beclomethasone formoterol, but it's not available in US in that format. Only for low-dose formoterol. So these studies are only done for 4.5 mcg or 6 mcg dose. There's a 9 mcg dose that's given in certain countries. It doesn't apply for SMART. ICS and salmeterol should not be used for SMART. So any other, except for Dulera, you can't use Advair for SMART. Other inhalers cannot be, or Vixella or other things that cannot be used. Where does FDA stand on this? None of this is approved by the FDA yet. None of it. But it has approved something else, and it's not as useful for us, but I just wanted to bring it up to you so that you know that it's there. It approved Air Supra. I saw it at a recent conference. It's approved for 18 and older. Usually you can extrapolate the data to a pediatric age group, but it's budesonide and albuterol inhaler solution. It's a dry powder, and it's only recommended for as-needed use, not even for every day. So I don't know how useful it is for me, but there are patients that have been using it in the adult world. It's new, though. It's very new. It's maybe the last 3 or 4 months. So that's all we have from FDA for combination inhalers. We're hoping that we get more in the next few months. Let's see. Barriers to introducing SMART. It's not currently approved. Insurance may have issues, so that's the thing. Extra cost. A lot of patients' insurances don't cover Symbicort. And at that point, there's one, I forget the name now, but I had a recent patient that none of the combinations in an HFA form were covered. So it was only a DPI for a 6-year-old. And I'm trying to see, and there is no peer-to-peer option. I mean, this is just not acceptable. I think there's insurances like that. Because of cost, they will not do it. In this case, like, we are trying to go around somehow, like doing, again, you can do extra ICS, so you can do Flovent 220 in these cases. Not ideal, but it has worked in the past, so we can keep using. Extra inhalers for school and action plans of schools are always a concern. I always tell patients, if you look and open the package insert for these medications, you're going to get scared because it says it's not approved for under 12 or under 5, and it's not approved for reliever therapy. It actually says, and it says causes death in patients who use it for reliever. Because of the LABA black box warning. That was years ago, which is actually now gone because of, if it's in combination with an ICS, it doesn't exist, but they have to keep it there. So I will tell them that when you look at the package insert, it's going to say it's not approved, but it is not approved by FDA, and I will tell them that. And I have had one patient who says, if it's not approved by FDA, I'm not using it, which is fine. At least we gave the option. But then this is important to just tell the patients that. Asthma action plan, this is the only one that's out there for smart therapy. This is from a group in Australia. Yes. And it's I can even share my slides later if you'd like. It's from a group in Australia. I have talked to colleagues at CHOP and Children's National asking for more asthma action plans. If they have any, I have not found any so far. We've started using our dot phrase that we try to use, and I can share it if you'd like. Yeah. So we can do. So I can walk through. This is very wordy. For any patient, if I'm going to give this, I'm not going to read it myself. So I don't know who will read, but we're trying to work on this. So in green zone, it's basically saying you use, so there's a checkbox here that you can kind of check which inhaler. You can check how many in the morning, how many in the evening, and you can reuse a reliever, and you can use a checkbox there. For yellow zone, you say for a period of 2 to 3 days, you can use your Symbicort. And it says, if using more than 6 inhalations in a day for 12 and older, or more than 4 in a day for 4 to 11, call us. But the big thing is there is no red zone in smart therapy. At that point, you're already getting oral steroid. So there is no red zone where you take back-to-back albuterol therapy. At that point, you're just coming to the emergency room. So they are talking about here where you can use Symbicort, 1 inhalation every 1 to 3 minutes for 2 to 3 times. And then that's it. But if you don't have Symbicort, you can take 4 puffs of albuterol at one time and come to the emergency room. So I'm telling them, if you're already using smart therapy for 3 days, that's like you're already getting a lot of inhaled steroid, might as well. At that point, you would do a steroid course.
If they present to the emergency room,
yes,
can we continue with what we've traditionally been doing, which is usually the cybotherapy of the
absolutely,
and the whatever rescues,
Absolutely, great question. Because nothing changes in the emergency room or the inpatient setting. Everything, acute asthma, flare-up, nothing has changed. This, I think, is a great way to, the best way to catch patients is at discharge, I think, from the hospital. And if they are not controlled on a therapy, and this is what we're trying to do at Maryland now, is that patients who are uncontrolled on a low-dose steroid and come in with a flare-up, we do our regular status asthmaticus management. And in the end, before discharge, the day before, we talk about smart therapy for those who qualify. And we send them home with 2 inhalers from. So 1 is definitely used because 1, we start Symbicort in the hospital, so they're going to go home with that. And then we can use 1 we can give a prescription for 1. So that's the beauty of inpatient setting. You can start patients then if you're concerned. And I think parents are also more receptive at that point. So so that's I cannot emphasize enough about spacer technique, and many a times they're not using that, not using a spacer or a mask. For older than 8 years, you use just a spacer. For under 8 years, you're using a mask as well. Always going through that, and that remains the same, going through education of asthma, spacer, compliance, all of that. So my conclusion here is that smart therapy is recommended for moderate to severe asthma in patients who are older than 5 years only and who are not controlled with a low-dose ICS. I mean, if you have a patient who's well-controlled, I won't switch. I won't do anything because it does need a lot of repetitive education and a whole change in the thought process, which I think they're more receptive to when they see that their child is not doing well. Shown to lower the risk of asthma exacerbation by approximately 35%, equivalent to a biologic. And I think that's something I tell parents a lot. Lower growth suppression than traditional treatment. Currently, this is all off-label, and consistent education and reinforcement is required at every visit. And that's the end of my presentation. These are my references. There's a lot of research out there. I can personally share it with you if you need. And then if you get a chance, you had those, I didn't know you had those evaluation forms, but either one, if you can even scan this and send this goes directly to Qualtrics. So that'd be awesome for next time. Thank you for your time.